Good morning, and thank you for attending our conference workshop on complications of obstetric fistula. The disclosures are certainly not relevant to this field in which there is no money to be had. Just reminders, please silence your cell phones, and if you need to take a call, please step outside the room. And please do not take photographs of all the slides. All of the slides and the speaker handouts are available on the ICS website. So afterwards, they'll be turned into PDFs. You can download them. And if I am incorrect about that, I'll be held personally responsible. I've been promised by Dominic and the IT team that all slides will be available. My name is Christopher Payne. I'm a urologist in San Jose, California, and a member of the Board of Trustees of ICS. I'd like to kind of initiate things by a little bit of perspective about how the world of obstetric fistula has changed. I think the big goal 20 years ago was to make people aware of this terrible problem, the extent and severity of the problem that was hard for people in the developed world to understand. I remember going to I believe the second international consultation on incontinence and hearing Lewis Wall give an impassioned speech about this problem and thinking this is perhaps something I could make a difference in and should get involved in, and got me interested in learning more about obstetric fistula. Many other people became aware of the problem with the movie Walk to the Beautiful about the Hamlin Fistula Center and Catherine Hamlin's life. And then, at least in America, a lot of people became energized when Lewis Wall wrote articles about the problem of obstetric fistula in the New York Times and in his book, Half the Sky. As we look out at the environment now, things are a little different. If you look across the developing world, we see a good number of outstanding surgeons. We see people and governments aware of the problem, trying to develop strategies. And if you look at the centers, at least that I've been involved with, we're actually seeing some decline in the number of cases each year. And it's very clear that progress has been made, and it's not as clear as to what the immediate most important needs are. We are becoming much more aware of the breadth of obstetric complications. And by this, I'm going to imply both what we're talking about today, which are the other problems after closing an obstetric fistula, but also the millions and millions of women in the developing world who have lesser complications than obstetric fistula. Stage 4 prolapse is epidemic. Incontinence that's not due to obstetric fistula is going to be epidemic as people become more urbanized and more empowered to access medical care. And we're very, very far away from the future that we want, which is safe deliveries for all women. So that's just a little bit of a perspective. So as we look at obstetric fistula in transition, I would like to kind of draw some parallels to our understanding of incontinence in the developed world. So we're seeing fewer cases, we're seeing better surgeons, we're seeing women get the fistula closed, but now we're looking more closely at what are the actual outcomes. Just saying that the fistula is closed is not enough. When I started training in urology in the 1990s, and I see some other people here who will have a similar background, similar age, we learned that all stress incontinence surgery was perfect, that our patients were 100% dry, and the biggest argument was whether if I trained with Shlomo Raz versus you trained with Ed McGuire or you trained somewhere else, why my approach was better than your approach, but we pretty much all knew that we were getting perfect results. Well, that was blown apart with a few articles in the 1990s. One where we looked at, instead of the reported outcomes, we did chart review 5 years later, and we saw that these reported outcomes that were 90%, 95% initially were more like 60% or 70% at 5 years. Another article that looked at what the surgeon said the outcome was versus what the patient said the outcome was. And again, we had 90% success when you look at the surgeon's charts, and if you ask the patient that, the actual results were more like 60% success. So when we start applying these type of approach to the world of fistula, we're going to learn that we have a lot of work left to do. And in order to know what our outcomes are, we do need to know the anatomic outcome. We do need to know whether the hole in the bladder that was identified, did the hole get closed? That still has to be an important outcome. But we need to know the functional outcome. Can the woman urinate, and is she continent? And we need to have some assessment of the patient perspective. How does the patient feel? Are they restored to ability to live? And then we need to know durability. And of course, for the most part, this research, these outcomes are not available in the world of obstetric fistula right now. So I would like to present a little bit of data from one center, a center that I work with in Niger. This is our wonderful surgeon, Etengre Ouedraogo, who's Burkinan. And this data I will not go into in detail because the data is in press, but I will encourage you to look for the results when it comes out. So Etengre has done a 6-month follow-up of his patients. We do have anatomic outcome as to whether the fistula is closed by a dye test. We don't honestly have functional outcome. We don't have any structured way of saying, does the woman have stress incontinence? We didn't systematically get PVRs and record the PVRs in everyone. We don't know whether the bladder holds adequate capacity. We do have a simple patient perspective. Are they wet or dry? And we do have durability. So we have a first effort to do something a little bit better. And this is our results. Now just look at this one category here. Closed and dry. These are the patients who, by a dye test, the fistula is closed, and the patient says they're dry. And it's pretty easy to see, without studying the whole data, that success rate drops off dramatically using the scoring system that we use in this paper for the complexity of the repair. And yes, we're getting 90% success rate, closed, dry, 6-month follow-up for easy repairs. But we're getting 1 out of 3 success rate, closed and dry for difficult repairs. And again, I'm going to encourage you to look at the article, but difficult repairs are often the 4th or 5th repair, or heavily scarred, complete loss of the urethra, bladder, neck, the usual type of scoring systems that we see. And we don't have data about sexual function. As mentioned, we don't have data on functional outcomes. We have very limited patient perspective data. And I think this is an enormous challenge. How do we gain patient perspective in a patient group that is largely illiterate in their native language? They only speak their dialect, they don't write. And they speak many, many different dialects in most of the centers. And we think we have made a contribution by looking at the durability. So we have a great opportunity to explore some of these issues today. We're honored to have Dirk de Ritter here, professor of surgery, who has a long time association with the center in the Congo, where he's been going to help with this case. And I'm still optimistic that Dr. Fakade will show up. Dr. Fakade is the director of surgery at Hamlin Fistula Center in Addis Ababa. And, and there's a little misspelling there. He is one of the first 2 urogynecology fellows in Ethiopia. So he's already a highly qualified OBGYN and fistula surgeon, but he is studying to become a fully trained urogynecologist so that he can bring that aspect of training to the next generation of gynecologists and start urogynecology fellowship programs in Ethiopia. So if we can bring up Dr. de Ritter's slides.